Welcome to another just-in-time video from the RAPM Network. Today we're going to be talking about pediatric high-flow nasal cannula protocols with Dr. Mary King. Now, Dr. Mary King is a pediatric intensivist from Seattle. She's the medical director at the trauma ICU at Harborview Medical Center, also works as an intensivist at Seattle Children's, and she's the associate medical director of the Washington Medical Coordinating Center, where she set up pediatric protocols during last year's triple-demic. Mary King, thank you so much for joining us today.
Great to be here, Jonathan. Thank you so much for having me.
Now, about a year ago, we were in that triple-demic. Hospitals everywhere were full of kids who were sick with COVID, RSV, flu, or two or three of them at the same time. Hospitals were full. It was incredibly difficult to find beds for patients who needed escalating care. And you in Washington were right in the middle of that. Tell us about some of the lessons that you learned and some of the systems that you set up in Washington, which really became a national leader in capacity management around the triple-demic.
Thank you, Jonathan. Yes, it was a really challenging time for pediatrics. And it wasn't just for pediatricians. I would say it was a most challenging time for some of our ER doctors, some of our community hospitals, but pediatricians alike. And that's because so many children became ill at the same time. Unfortunately, our pediatric system just doesn't have the same capacity in it that our adult system does. But we had the really good fortune here in Washington that our adult colleagues had already worked together and built a system during COVID that's known as a MOC, or a Medical Organizing Coordination Center. And they built that MOC. It was called the WMCC through Harborview, where I happened to work as a pediatric intensivist, in part because they're so engaged in the trauma systems. Regional triage and distribution is really their expertise. So when the triple-demic did hit, I had friends and colleagues that already knew a lot about how to distribute patients across a regional system of resources. They already had data management streams. They already had nurses who were used to doing this, who already knew all these community hospitals. So I was able to partner with them and build a pediatric arm to our Washington MOC. And so, there's no way we could have gotten through this without our friends and colleagues. The other really essential piece was the relationship building that had already been done by our local healthcare coalitions. The Northwest Healthcare Response Network was really critical. I've been active with that for many years now, but those relationships that were already in place were crucial in developing some of those agreements or MOUs with the state and healthcare authorities and all of those pediatric hospitals to join our Washington State MOC. So I think it's a combination of teamwork across our state that really helped. I would say one of the biggest barriers we have in Washington is geography. We have a lot of kids throughout the state that are far away from medical resources or pediatric medical resources. And far away in terms of distance, but also far away in terms of mountains and waters. So there's a lot of unique challenges there. But we did learn a lot last year.
Yeah, and I'll say that watching your group from California, where we have no unified data infrastructure to help us understand where capacity exists and who's deeply impacted, was really striking to see the difference between a state that has a really robust system in place and a place that's trying to sort of put it together on the fly. Tell us about some of the things that you've learned about in terms of how to manage high-flow nasal cannula protocols specifically as we face another viral season that's coming up. Like, let's say, for example, you're in a small rural emergency department and you've got a 1-year-old kid with a URI for a couple of days who's had some increased work of breathing. They're now in your emergency department. They're on 12 liters of high flow nasal cannula. And you call your usual pediatric referral center and they say, wish we could help you, but we're full.
Jonathan, that's such a great question, because that question happened over and over and over last fall. And I know I'm not unique in that experience. Patients just like that presented and will present again. And so one thing that was unique at the WMCC for children is this detail about high flow nasal cannula, because it really is a critical capability for delivering care to these sicker children that's different than adults. It's just not as common of a modality. And in our hospitals in Washington State, there are some hospitals that can deliver high flow nasal cannula and some that can't. And there are some that can deliver it at certain levels and some that can't. And so what we learned is you have to know the details about your high flow nasal cannulas. So there's variation in local practice. There may be different respiratory therapy personnel and equipment. And frankly, there's just different protocols hospital to hospital. There's just not been a standard approach universally. And then also, the maximum flow that a hospital may be comfortable delivering to a child may be different, depending on whether they have an ICU backup or not, because they may want to be able to rescue that child sooner before they decompensate, as compared to if they know that they have an ICU right upstairs. So those were some of the really critical pieces of the high flow nasal cannula protocols that we found that we needed, because initially when we started this mock, that granular level detail of, okay, you're a community hospital that sometimes admits children and gives them high flow nasal cannula. What does that really mean? How much high flow can you actually provide? Do you have an age limit? And so we needed that information in order to place a child.
So one of the things that sounds like is really important is that visibility, being very open with the medical community around you about what you're comfortable managing and what your protocols will allow you to do, right? Like everybody
Definitely.
needs to know what everybody's.
Yeah. And it was actually a process for us because we initially did not have that visibility when we stood up our mock. And I would say definitely the outlying community hospitals didn't have that ability. So if they had been instead calling hospital to hospital like they typically do, they're going to get different answers from every hospital depending on what their protocols were, but they didn't even know what those protocols looked like. So it's hard to know who to call.
So let's apply that to our patient here. So, our 1-year-old on 12 liters of high flow in the community ED, probably starting to feel like maybe we're getting towards the upper range of what we're comfortable with in our 25-bed, no PICU emergency department with no pediatric support. What's next? How do we figure out how to best transfer that kid, where to transfer them, and what do we need to think about as we're preparing for that effort to find a higher level of care?
Yeah, definitely. Well, I think so. There's two things to think about here. There's finding the bed. That's the first thing. And then the second thing is ongoing care. I'm not going to even get into the ongoing care issue, but definitely I feel like you guys should have the support to have ongoing care of that child that's in place while you're trying to find a bed. So that may be getting on the phone with your pediatric center who said, okay, they can't take the child, but can you talk to a pediatric ED doc or a PICU doc to make sure that you feel comfortable with your care questions. So that's one piece. But what I'm going to talk about is how to find that bed for the child. So what you've already done, Jonathan, really nicely is you clearly laid out what the high flow nasal cannula needs of the patient are. So that's one thing. Another patient specific piece of information that you'll really want is, Are there any other potential complicating medical factors for this child? Is this a previously healthy child, or is this a child who was a former NICU grad who had some pulmonary hypertension? I may think differently about those two types of children, independent of where they're at the high flow. So that's the patient level info. Then we need to get to the hospital level info. So when I'm thinking about hospital level info, I need access to what you referred to before is just really kind of a data dashboard for the whole region. I need to know where that capacity is in the system. So what hospitals have pediatric beds, and then at what level care can that pediatric bed deliver? So specifically, I need to know the potential receiving hospital high flow nasal cannula protocol details, the presence of a pediatric acute care ward, a pediatric hospitalist, and then is there a PICU or NICU willing to provide backup or admit if I think that's necessary? Now, for the patient that you're describing, I'm imagining there's no complicating medical factors, as it sounds like a previously healthy kid on relatively low levels of high flow nasal cannula. So probably this could go to a pediatric ward that has a pediatric hospitalist without an ICU, and that would be appropriate. So we need to know if number one, the patient matches number two, the hospital. And then lastly, we also need to know that we have a transport company that's willing to transport the patient on this level of high flow nasal cannula. We ran into some issues last fall where certain transport agencies were called and said they would not be able to deliver the humidified high flow nasal cannula and instead would have to intubate the patient for transfer. So that also is not ideal. So those are really the data pieces of what we need to make our decision. And I guess I'll stop there and see if you have any questions.
Yeah. So I guess right, thinking about that prospectively, from my position in this small rural emergency department, it would be helpful for me to either live in Washington State and have a central number I can call, or, at the very least, maybe have a list of all the hospitals that could accept peds and kind of what their level of care would be. And then I can sort of make that assessment, like, does this kid seem like they're going to need an ICU, or could we just transfer them somewhere where they could be a pediatric ward inpatient? And then also next to that, a sheet of paper that says, here are the transport facility or transport teams that are capable of transporting on high flow nasal cannula. So we should be calling them as opposed to people who are going to come rushing in with their endotracheal tubes in hand.
Yeah, I think you described it perfectly. I think, in Washington State, we're a relatively small state. We had geographical pressures that forced us to play in the same sandbox. So we were lucky because we were kind of, I don't want to say forced into a mock, but it just made it easier that was the solution. In a much larger state with larger populations, many more systems of care, less geographical pressures, I can understand how going to a mock is a pretty high bar. And so sometimes it may just be about your region. And so, yeah, it may just be the pediatric center answering the line and trying to help this community hospital. Or it could be a community hospital stuck on their own. And so what I'm trying to provide is some tools to kind of all comers about what are those essential data elements that we need, both at the patient level and the hospital level and the EMS level, to make some of those decisions. In an ideal world, I do think some amount of visibility is really ideal, and I will almost say necessary to achieve this. Because without that situational awareness across all your partners, it's really hard to make sure that everyone knows they're kind of pushing the gas pedal at the same time together. That was also something we learned. It really, really helped us to know where each other stood. I did take it one step further, and based on my experience last fall, what I did is take these factors and kind of come up with a grouping mechanism of patient risk for pediatric bronchiolitis patients on high flow nasal cannula. And so I separated them into 3 different groups. And based on that risk category, then you could think of sending them to a different pediatric bed type. So what I did for lower risk patients, those patients could receive ongoing care in place, potentially with some consultation by phone or telehealth, or they could go to a pediatric acute care ward without ICU backup. Be that PICU or sometimes NICUs would help out for our smaller patients. For a moderate risk patient, now that might be a patient that's at higher risk to decompensate. Maybe they're on higher levels of high flow. Maybe they have some risk factors. That's someone you might want to think about putting in a pediatric acute care ward with a pediatric hospitalist where there is an ICU backup in that hospital. So if that patient were to decompensate, they'd have rescue. And then lastly, there's the higher risk group of patients, and those would have to go to ICUs. And this was actually helpful because at the WMCC, when we would get calls on occasion, we would get calls about patients who we felt were in that kind of higher risk category. And we would call the pediatric centers back and say, I think this child really needs to be in an ICU in your hospital because there is no other safe option for this child.
Yeah, I mean that makes so much sense. Let's put that kind of on its feet, and I'm going to change one number. So we're going to go from a 1-year-old to a 3-month-old, but everything else is the same, including that 12 liters of high flow nasal cannula, right? So now we've gone from a kid who was maybe getting half a liter to a kid who's getting 2 liters a minute of high flow. But still, in the ED and in this rural center. How does that change your thinking when you're dealing with a more acutely or a more seriously ill child who is younger?
Yes. Jonathan, you're bringing back memories for me because I did receive those phone calls and I can hear
We
them.
all have a little PTSD from
Yes.
last year.
We do. And this is my real human response to this question is I still remember the voice and the tone of my rural emergency physician colleagues telling me, like literally, Dr. King, you realize I'm having a heart attack every minute knowing this child's in my ER right now. You understand how many ER doctors are panicking right now. And so I think this question is really important. And I think sometimes we have to have a system where the buck stops with us and we say, wow, this is not safe, period, because this child could die in that ER. I'm very concerned that child could be unnecessarily intubated or have someone who doesn't have the experience with that level of respiratory support. And that's a child that does not need to die in a pediatric center. And so that was one situation even last fall where we started hearing about these really, really critically ill small infants in rural ERs. And we were able to say, wow, these are really, really high risk patients. Let's call our pediatric centers and say these kids need to be in them. But B, is there another solution? Could this child be cared for in a NICU? Typically, our NICUs don't admit children from the outside world. They admit them after they are born.
And especially not if they're germy.
Yeah, not those sick babies. That's right. Because the concern is bringing illness and sickness into neonatal ICUs, which I 100% understand. However, is there a way that we can take care of those very sick infants in NICUs in a way that can be safe, where we can cohort these children, where we can potentially cohort their care providers away from the non-infected children? Well, when we started hearing about these really sick infants in ERs, we were able, with the help of our coalition, to contact the medical directors of all of our pediatric hospitals and bigger hospitals with NICUs. And we got a bunch of our NICU leaders throughout the state on the phone so that they had situational awareness about what was going on. And when that happened, it's like a light went on, because everybody understood how sick these kids were. And there were many things that were done at many levels to create space, whether it's keeping a child like that at the community hospital that happens to have a NICU that can do some, moderate level NICU care, and high flow nasal cannula, CPAP, and endotracheal intubation, frankly, aren't challenging for them. That would be amazing. And so in some places, we were able to keep that patient at that same hospital. In other places, we were able to say, well, we can't admit them to the PICU because we don't have any PICU space, but let's see if we can admit them to a NICU. So we were also able to do that and create space in our NICUs. It wasn't all of our NICUs, but it was some of them. And then one other thing that just happened, even within the NICU communities, we started getting a little bit fewer calls to our WMCC, and some of those kids just started getting directly admitted to NICUs. So it was a community-wide effort, and those were very, very scary patients for our rural EDs. And so I'm continuously grateful for our NICU colleagues for leaning into that.
Well, thank you so much. I think this is just such important work that has really elucidated and clarified what I think is, so easily becomes a very complicated multifactorial picture of who goes where and how do they get there. But you've really distilled this nicely into actually a one-page document that we will have available on the RAPM website. And I can't thank you enough for taking the time to talk to all of us about the lessons learned from last year's triple-demic. And here's hoping we don't have to implement too many of them again this year or in the years to come.
I'm right there with you, and it's really been my pleasure to be here. So thank you so much for partnering with me.